see what I can do. I have no financial disclosures other than that I do both cornea and glaucoma, so I can just refer the complications to myself, stay busy. There are a lot of corneal problems after glaucoma surgery, most of which we'll kind of skip over and just focus on the corneal endothelial decompensation and then corneal graft rejection. I think you have to be specific about what type of glaucoma surgery, and then that leads to the problems with the cornea. So let's just break it down by MIGS, trabs, and tubes. So thank you very much for that introduction with the SiPass, but basically with MIGS, there aren't many problems with the endothelium. There are a couple case reports with MIGS prior to this, or there's endothelial or corneal edema after MIGS, especially when they're combined with cataract surgery, but it resolves until we had the recall of SiPass, which I think most people are aware of. Stents too long, too anterior, touches the peripheral corneal, the corneal endothelium, and it decompensates. And you showed how to fix that. Thank you. But it's good to remember why that happens, and we'll come back to that. So how about corneal edema after trabs and tubes? How often does it occur? We can look at the 5-year TVT complication report, and in 9% of trabs and 16% of tubes, there was persistent corneal edema. It was the most common cause for reoperation for a complication, not reoperation overall, but for a complication. It was also the most common cause for loss of 2 or more lines of Snellen vision. 16% and 9% in those patients is quite high. Obviously, these are patients that had prior intraocular surgery. They weren't the first surgery that they underwent, but that's a high, high number. So what about graft survival? This is something that maybe we as glaucoma specialists aren't as well aware, but look at this. There are lots of different publications on this topic. I just picked one. I guess I have another, but maybe I'll skip due to time. Look at this chart. This is the graft survival over time in eyes with different medical, surgical, treated glaucoma. Grafts do well with no glaucoma. Good. Medical controlled glaucoma. This particular chart says it's pretty close to no glaucoma. I'd probably argue that that's not exactly true, but just bear with it. Prior trabeculectomy, it goes along okay, and then it just falls off. Prior tube shunts, the success of a DSEC or a corneal transplant after a tube shunt is pretty abysmal. It's terrible. Look at this. It's down close between 20 and 30% after 5 years. How many of us would do a trabeculectomy or a tube shunt with 20 or 30% success after 5 years? It's terrible. That's what we have to deal with as corneal surgeons. It's just another study showing basically the same thing, that both trabs and tubes lead to significant corneal edema. They both shorten the survival of corneal transplants. It doesn't matter the type, if it's a PK or a DSEC or a DMEC, it's going to shorten it. Tubes lead to worse corneal edema and worse graft survival. Why? There's many different theories and reasons. The surgical insult, hypotony, postoperative hypotony, those are pretty obvious, but they're a single insult right around perioperatively, right around the time of surgery. What about disrupting the flow inside the anterior chamber? That can be an ongoing problem or a change. It can be from a trab or a tube. Damage from the tube. Direct damage from the tube entry site. The tube, when it enters the eye, we don't place tubes ab internal, we place them externally, and the tube should enter through the trabecular meshwork. How many people look at them with gonioscopy postoperatively? I don't think enough of us do. And I think that this is one of the main causes for tube shunts leading to corneal endothelial decompensation and graft failure. There's also altered inflammation and immune privilege in these eyes. Also goes along with especially tube shunts more than trabeculectomies, but that gets to your reduced graft rejection. Here are just a couple diagrams to show the tube position and things to think about. The blue line represents where a tube shunt may be entering, and just if I tell you, well, this enters through the trabecular meshwork, you might say this is a good tube shunt. It's down along the iris, it's deep centrally, and if I tell you it enters through the trabecular meshwork, thumbs up. What about this one? It's more anterior. Depending on your slit lamp view, you might be deceived and think, oh, this is still deep in the eye. But if you look on gonioscopy, this is going to enter through the peripheral cornea, just like SiPass when it was recalled. This is going to cause the same problems 3 years and 5 years and ongoing to the corneal endothelium. What about this tube? This is a more obvious one that's poorly positioned. It's angling towards the cornea, it's more anterior, but also its insertion. Here's just a slight variation. It's got the same trajectory inside the anterior chamber, but its entry might be better. Might be through the trabecular meshwork versus this one, right? So an entry through the trabecular meshwork is very important. One tip that I've seen over time, you see these, here's the pointer. How can you tell that these two tubes enter the eye improperly? You don't even need gonioscopy. You look right here at the slit lamp. You see this white little stripe? And it's very obvious here, this white little stripe right here. You don't need gonioscopy. You can tell that that enters through the peripheral cornea. That's what that reflection is. But if you don't believe me, you put on a gonioprism like I think we all should, and we see that these tubes enter through the peripheral cornea. They don't enter through the trabecular meshwork. So over years, 3 years, 5 years, just like SciPass data showed us, these corneas are going to decompensate. So corneal edema after glaucoma surgery, what can be done? It'd be nice, or in the instance of trabeculectomy, avoid hypotony. Sure, that's easier said than done. Use plenty of steroids, that's a good idea, sure. Tube shunts, perform gonioscopy is what I would recommend. The tube should enter through the trabecular meshwork, not anterior to Schwalbe's line. Insert the tube in the posterior chamber if a patient's pseudophakic. This is at the time of surgery. And if it's a poorly positioned tube that you see, postoperatively, reposition the tube and insert it in a better position. An ounce of prevention is worth a pound of cure. Why? Remember those survival curves of a graft in an eye with a tube. So prevent this damage. So how about glaucoma? Why is it worse after corneal surgery? If you break this down into two different categories, medically controlled and surgically controlled glaucoma. We'll break it down in another slide in a second. Medically controlled glaucoma, most commonly you're going to get steroid response, and you're going to also get angle closure, reduced outflow through the trabecular meshwork. These are the eyes that probably most commonly end up progressing or needing surgery, are eyes that have medical control. Not patients that don't have any glaucoma to begin with, but these medically controlled patients are the ones that are going to get worse after a corneal transplant. Surgically treated glaucoma, such as trab or tube, you can get occlusion of the tube itself or the trab ostium, or just progressive angle closure. Maybe there's some component of steroid response as well. How about we break this down into the type of corneal procedure? What's going to happen in your PKP case? You distort this angle structures and you get less outflow. You also get angle closure that usually occurs kind of creeping slowly over months, and you also get steroid response. DALK is probably the best corneal operation, and you should talk to your corneal colleagues and encourage them to do DALK. You get less PAS, and you're probably not going to need much steroids. So encourage them to do DALK instead of just PKP when it's appropriate. EK, steroids are the most common, and then a preventable form of angle closure, pupillary block. So just be aware that keratoprosthesis, refer to Dr. Lind. They're very difficult. They often get angle closure. So glaucoma is worse after corneal surgeon. What can be done? Coordinate with your cornea specialist about the type of topical steroids that can be used. If iris is plugging a trab or tube, it's often amenable to just vitrecting it, removing it, cutting away the iris that's causing the offending problem. And if your glaucoma surgery is needed, remember the graft survival curves that I showed you before about tubes specifically. Thank you.
Great talk, Mike. Excellent. So we'll give everyone a chance to re-answer this question. All right, great. And we'll have Dr. Vijayanant's ARS question.